We are live, ma'am. We can start.
Yeah. Hello, everyone. Good evening again. I'm Dr. Shailaja Kale from Diabetes Dilemma. As the tagline says, it's a brainstorming the burning issues. We know all the subjects and the titles are same, but we are trying to create more awareness by different questions. So this is a series of scientific program, and today we are going to discuss very interesting topic. I have with me Dr. Valentin Lobo. He is a nephrologist heading the department of the kidney as a nephrologist from Pune King Edward Memorial Hospital. He himself is a DNB teacher and extremely well respected at a very young age as a teacher as well as a nephrologist in the city of Pune as well as outside. So welcome, Dr. Lobo.
Thank you.
I have Dr. Avdesh Singh who is there joined. He is an endocrinologist from Kolkata. He has many awards to his credit. We all know for his publications, latest publications, I think big series from India. It becomes easier to know the topic when you read Avdesh's publications, which actually gathers a lot of information and gives a good output. So our work goes down. Plus, he's extremely well kind of a speaker, which makes all the topics very easy. All the big orations in India at young age he has a credit of speaking and delivering all the orations from different conferences. So welcome Dr. Avdesh Singh from Kolkata. Thank you so much for joining this Diabetes Dilemma series. So today's flow is that we just discuss few aspects. जरा ऐसे करून दे Also, I will like to thank our today's sponsor USV as well as all my other sponsors from the Diabetes Dilemma. Presentation. So let's start from the glucose filtration and get the slide. Slide open karna. You come down. You come from here. Don't worry. Come from here. So Dr. Lobo, I want to ask you about. Come here. Will you please start the slide? So glucose filtration we usually say, and we all know that there is a genetic condition which is glycosuria,
Right.
and where there are no problems.
Yeah.
And then the SGLT2 inhibitors came, which produced glycosuria.
Yeah.
I remember the first program in Pune. I was quite young that time. After the phase 3 programs, the SGLT2 inhibitors were introduced. And so when we presented the data, I was a part of canagliflozin and dapagliflozin trials, and it was first time DAPA came into the market. All my colleagues in Germany were using it very frequently. But we got too much of bashing from all our senior professors in Pune that what is it happening? How can you use the drugs which are pushing so much of glucose in kidney? It is wrong. So these new people are not doing a justice to the patient. So I remember that meeting. We were very depressed, and now we can see after 10 years where are we that actually these drugs are next to the God, next to the God. So just can you just explain my viewers about glucose filtration, and when we say it shifts to the right, what do you mean by this?
Right.
And how it happens in type 2 diabetes?
Okay.
Yes, I'm trying to do the slides, but you can explain. Yeah.
As we all know, glucose is a small molecule. So, like all small molecules, it is completely filtered at the glomerulus. It reaches the proximal tubule where the sodium glucose co-transporters are. What Dr. Kai was saying, the sodium glucose co-transporter 1 and 2. Now, what these transporters will do is to co-transport sodium and glucose into the tubular epithelial cells. Obviously, the transporter has a certain capacity to transport the filtered load of glucose. The filtered load of glucose reaching the proximal tubule is a function of the blood glucose, the plasma glucose level, and the glomerular filtration rate. Once the filtered glucose load overwhelms the capacity of the proximal tubule receptors to be reabsorbed, glucose will begin to appear in the urine. Now, therefore, it follows that if this is and this normal value is around 180 to 200 milligram per cent. This value at which of plasma glucose, above which glucose begins to appear in the urine, is sometimes known as the tubular maximum for glucose. And this tubular maximum for glucose is normally a value of around 180 to 200 milligram per deciliter. Now, if the GFR begins to fall, we've got the slide now. So that's the tubular maximum for glucose there. This is the filtered glucose. Once the tubular maximum is exceeded, glucose will begin to appear in the urine. Now, if the filtered load of glucose is a product of the glucose, plasma glucose, and the eGFR, as the eGFR drops, the filtered load of glucose. So as the glomerular filtration rate or the kidney function goes down, the filtered load will decrease, and the value at which the TM, the tubular maximum for glucose, is reached will come at a much higher value. So the curve shifts to the right, and this value can go up to around can go up to around 350 to 400 in end-stage renal disease. Now, what the sodium glucose co-transporters do is essentially, because they block the reabsorption of glucose, a larger load of glucose and sodium will be excreted at a lower value of the plasma glucose. So they shift the curve which has moved to the right back again to the normal value, or shifted to the left.
Yeah, because we always hear this shifted to the right, and then we want to normalize this glycoside. So now my next question is, why albumin comes in the urine?
Right.
What is it that happens in glomeruli and the albumin comes in the urine?
Right. So we say that glomeruli have a filtration barrier. This filtration barrier is made up of 4 layers. There is the endothelial cell, which is a fenestrated endothelium. That is, it has got large fenestrae or windows in the cell. Then there's a glycocalyx which surrounds the endothelial cell. Then comes the glomerular basement membrane itself, which consists of 3 parts: the lamina densa and the lamina densa, and lamina rara interna and lamina rara externa. And then we have the tubular epithelium, which is a specialized epithelium, which is a number of interdigitating foot processes. And so these tubular epithelial cells are known as podocytes. The podocytes have a large number of specific proteins which are expressed: nephrin, podocin, actin. So that it has an actin cytoskeleton and various transporters. Also, what the glycocalyx and the endothelial and epithelial cells ensure is that there is a size selective barrier and a charge selective barrier, which is made up mainly by the negatively charged glycosaminoglycans in the glycocalyx. So for a molecule to cross, like charges we know repel, so negatively charged molecules will be repelled, positively charged molecules will more easily cross this membrane. Now, it can be seen, and it has been seen in a number of kidney diseases, that the normal interdigitating podocytes in kidney diseases become simplified, or the foot processes become effaced. And in this situation, the size selective barrier is disrupted. If the normal charge on the protein molecules on the podocytes is lost, then the charge selective barrier also becomes disrupted. And in this situation, even negatively charged molecules, or protein molecules which bear a net negative charge, can then be filtered and into the Bowman space, and subsequently into the tubule.
So ultimately, it's a podocyte injury.
It's podocyte
so
injury.
This podocyte injury happens, is it because of too much of glucose? Is it because of some endothelial injury by inflammation? Or is it because of increased intraglomerular pressure? So what is it that exactly produces podocyte injury? Because I read a lot of new molecules are coming which are going to have a direct effect on the podocyte injury, which may protect kidneys. So that was my question.
That's right. In fact, all primary glomerular diseases have recently been renamed as podocytopathies. And that's where we know today that almost all genetic glomerular diseases have the abnormality is in various podocyte proteins: nephrin in congenital nephrotic syndrome, podocin in for congenital focal segmental or genetic focal segmental sclerosis. In other secondary diseases, it is a combination of all the things that you just named. So what does happen? What happens is that, for instance, there is a certain amount of generation of free oxidative radicals. Now, when molecules like transferrin, ferritin, etc. get filtered, they release free ion into the glomerular space. This free ion, also known as catalytic ion, and a lot of work on this was done by my former chief, Dr. Rajapurkar, who showed that the progression of diabetic nephropathy could be linked to some extent to the presence of free ion in the urine. Now, what this free ion does is to generate reactive oxygen species which can produce podocyte damage. In addition, we know that there is this group of molecules known as advanced glycation end products, and the mesangial cells which form the space in between the adjacent capillary loops have receptors for the advanced glycation end products. When an advanced glycation end product binds to its receptor, the receptor is the acronym known is RAGE, then what they do is to change the phenotype of the mesangial cell, which is normally a smooth muscle phenotype, into a fibroblastic type of a cell, which lays down collagen and causes further glomerular sclerosis in this situation.
Yeah, so I just, because of your discussion, I remembered about iron, what you said.
Yeah.
But I'll come to that after this simple clinical question that we are asking everyone to do GFR calculation by. So the standard is MDRD.
Yeah.
So MDRD you download, you use the app and calculate. So what is the difference between these different GFR calculators?
Right.
I only thought extremes of BMI, and someone is very thin,
Yeah.
and someone is very obese, then this MDRD may give you a strange kind of a results. And this CKD EPI equation.
Yeah.
So will you advise all of us to use MDRD GFR, which is very simple, or will you advise something different?
Right. So the MDRD formula works as you just said. It gives problems at the extremes of age or extremes of BMI. It also has been best validated in patients who have an altered GFR or a low GFR. We don't know above 60 GFR how well it works.
I think with this MDRD,
yeah,
I think everyone has a stage 1 CKD. Because if you just calculate, and with simple things, so many of my friends and the patients go to the nephrologist and come back to me, they told me that I have stage 2 kidney disease when the person is extremely healthy. So I think this is a problem of MDRD, or because in normal GFR, I think there are issues with this.
Yes, there are issues exactly with normal GFR, and the CKD EPI formula actually works better above a GFR of 60 than the MDRD formula. Now, a study was done right here in Pune by Dr. Atul Moe and Dr. Shefali Gokhale. They used the isotope plasma clearance method, which is the gold standard for measuring GFR, and evaluated all the formulae which are available, the Cockcroft Gold, the modified MDRD, and the CKD EPI in normal individuals, and showed that the one which correlated best with the gold standard, or agreed best with the gold standard is more accurate to say, was the CKD EPI formula.
So I think nowadays we get apps where it gives the value of MDRD, then it says by CKD EPI. So it has become easier now for all of us to use CKD EPI. So I think we should see that thing, because we do get, and so the other question, with a lot of ferritin levels are actually correlates. So is that related to this iron, or
it probably is. So
because it correlates independently for the kidney disease, in diabetes,
and even in addition to ferritin, what is probably coming even more is now hepcidin.
Okay.
Yeah, hepcidin is protective to tissue against iron-induced damage, and we have been studying, and many people have been studying hepcidin in chronic kidney disease, hepcidin in acute kidney injury. We recently completed one such study in an ICU setting to show that low hepcidin and high catalytic and high iron values could, it was published, Dr. Rajapurkar's study was published in JASN, I think about 3 years ago in sepsis, to show that high catalytic iron was responsible for acute kidney injury. And one of our studies recently showed that low hepcidin. So ferritin, hepcidin, transferrin, we measure hepcidin.
So it's a routine test available in the laboratories?
It can be done. The ideal method would be by mass spectroscopy. However, there are well standardized ELISA kits now available, and we use an ELISA kit for measuring
So,
hepcidin.
so which gives an additional indicator
Yeah.
for the prediction of the
prediction
kidney,
of kidney
diseases.
injury.
Yes, kidney injury. Okay, that was a addition to the, I think, everyone's knowledge. So I think these are the standard 4 stages of diabetic kidney disease. And so just can we go back quickly to diagnose, because the next question is how to rule out non-diabetic kidney disease.
That's right.
Which is very important. So can you just go quickly about diabetic kidney disease, just to have a recap for everyone?
So diagnosing diabetic kidney disease, I think the best definition of diabetic kidney disease came from 2 editions old Oxford textbook of clinical nephrology, where he said it is the definition of diabetic kidney disease is in a diabetic individual, the presence of more than 500 milligrams of protein, not albumin, that's protein, along with retinopathy in the absence of urinary tract infection and congestive cardiac failure, defined diabetic kidney disease. So the key elements to that are you shouldn't have a systemic disease or a local disease like urinary tract infection. You must have proteinuria. We can go more specific and talk about levels of albuminuria subsequently, and you must have retinopathy. All of this holds good very well in, and we know the timeline in type 1 diabetes, but it's not so well in type 2 diabetes. In type 1 diabetes, there is a 90% concordance between retinopathy and nephropathy. In type 2, it's about 60%. So we do get type 2 diabetics with nephropathy without retinopathy and vice versa.
And so we also have non-albuminuric diabetic
We
kidney
do have
disease,
that entity also.
even in type 1 and type 2.
Type 1 and
So
type 2.
few cases there is a overlap. So there may not be any albumin in the urine, but
the
patient has diabetic
Kimmel-Stinn-Wilson
kidney disease, and sometimes there is retina is normal.
retina is
And still sometimes with the raised creatinine, no albumin, no retinopathy. So there is a possibility we are dealing with non-diabetic kidney disease in a person with type 2 diabetes. So we have a lot of things we rule out. We always rule out obstructive uropathy. I think Dr. Lobo has published a series of good series of publication from KEM about obstructive uropathy in type 2 diabetes. So we know that's treatable cause, and we always investigate a patient with her. So my question is, when the patient has a creatinine of 1.6 or 1.4, no albumin in the urine, I get a lot of patients who are treated as if the person has diabetic kidney disease. So is the RAS blocking drugs are helpful or harmful in these cases? That is my always a dilemma in practice. So I want to ask you this question.
So we all know that diabetes is a systemic disease, and that it's also associated with cardiovascular, peripheral vascular, and cerebrovascular disease. So macrovascular disease, we know that there is an increased atherosclerosis. And when there is increased atherosclerosis, there is a possibility of renal artery atherosclerosis with ischemic nephropathy, as it's called. Now, this is one situation where if you have bilateral renal artery disease, where ACE inhibitors and or RAS blockade would be completely contraindicated because there would be acute worsening. If it is, once we have ruled out that this is not an ischemic nephropathy due to bilateral renal artery disease, then there could be still a role for RAS blockade, because there are studies like RAIN which used RAS blockade in non-diabetic kidney disease and showed a benefit in such situations.
Like patient has sometimes renal cysts.
Simple
renal cysts,
simple
not
renal
polycystic kidneys, simple renal cyst. And then these patients' creatinine always moves a bit on the higher side. So should we put them on RAS blocking drugs, SGLT2 inhibitors, which Avdesh will also join. So how to, because we always see that slight increase in creatinine once we treat these patients.
So how much should we accept an initial increase in creatinine? Up to 25% from the baseline, provided there isn't hyperkalemia. The biggest limiting factor, I think, is hyperkalemia. And once we start RAS blockade, we need to repeat the serum potassium within about 3 to 7 days of initiation. If the patient develops hyperkalemia, then I would feel that these drugs are contraindicated.
But there is a benefit.
But there is a benefit.
There is a benefit. So one should not be shy away from these drugs, even
there
though
is
it
a
is
definite
not
benefit.
And about SGLT2 inhibitors, I think we discuss after Avdesh's talk, because I think he's going to speak on that. So I think just in 2 minutes, are we going through, or let Dr. Avdesh speak, and then just a small this thing about SGLT2 inhibitors. Can you just explain the basics?
Sure.
And because then we start the discussion and how they stop. Yeah.
Right. So this is a basic picture of the nephron, and what we can see is the glomerulus with the afferent arteriole and the efferent arteriole. The glomerular pressure, which is the driving factor for filtration, is driven by the difference between the pressure at the arteriolar end and at the afferent arteriolar end and the efferent arteriolar end. In the presence of overactivity of the RAS system, the efferent arteriole is selectively vasoconstricted, increasing the intraglomerular pressure. Increased intraglomerular pressure will cause an increased filtration, and an increased filtration means an increased load of sodium and glucose in the proximal tubule, which will then be absorbed. The increased absorption will augment the systemic hypertension by increasing the vascular volume. Now, there is also what is known as a tubular glomerular feedback. When there is a decreased sodium load to the distal tubule, specialized cells of the distal tubule known as the macula densa sense this, and they send a signal to the afferent arteriole, which has the juxtaglomerular apparatus, and these juxtaglomerular cells then secrete renin, which further activates the RAS system, increases the intraglomerular pressure, and increases the filtration. Now, what the SGLT2 inhibitors will do in this situation is to inhibit the absorption, which we saw, the massive absorption of not only glucose but also of sodium. They will therefore increase the distal delivery of sodium and inhibit the tubular glomerular feedback, thereby doing two things. They will reduce the intraglomerular pressure, which is probably one of the mechanisms of their renoprotection. They will also reduce systemic hypertension by increasing sodium and water absorption and decreasing the intravascular volume. Finally, we need to remember that these are all highly energy dependent processes which put a lot of load on the tubular cell mitochondria. So when this inhibition occurs over here of sodium glucose co-transport, even the basal metabolic rate of the proximal tubules will be decreased.
So just about this, one question before I invite Dr. Avdesh Singh. What happens to these kind of a sodium loss?
Right.
And is it the way the diuretic effect of SGLT2 inhibitor work? Does it remain?
Yeah,
And
it has.
how come the body compensates
Yeah.
it? Yeah.
So it has been shown to remain, and the important part is that it does not, like most other diuretics, it seems to be a well compensated, since there is both sodium and water loss in this situation, unlike all the other diuretics which cause either an increase in free water or an increase in sodium and can cause sodium imbalances. Sodium imbalances have not been reported with SGLT2 blockers so far.
So I think I thank Dr. Valentin Lobo. So we just end this initial part of some basics which we come across dilemmas in our day-to-day practice. And I welcome Dr. Avdesh Singh, endocrinologist from Kolkata. So Dr. Jai, will you please give him this thing? Stop sharing from this.
Yes, sir.
I will just do that. Yes, Dr. Avdesh Singh.
Yeah, he started.
Yeah, perfect.
Can you see my slides?
Yes.
Yes, yes, Avdesh,
Yes.
I can see you.
Okay.
Yes.
Perfect. Thank you. Thank you very much, Dr. Shailaja Kale, for this invitation. It's always a pleasure to be amongst the colleague. Dr. Lobo has already alluded us, what is all about protecting kidney, and a little preface to how SGLT2 work. Let us find out what are the tools which we have so far developed to protect diabetic kidney disease. That's what I'm going to talk in next 25 minutes or so. Let me take you through what is in this space in diabetic kidney disease. First of all, it's needless to mention that when you are having diabetes, you need to be concerned about protecting kidney, because diabetes is the leading cause of the kidney failure, not only in the United States, but across the world, as this data suggests. And then followed by hypertension, and then, intrinsic renal disease, etc., etc. Also to understand that once you develop diabetic kidney disease, chronic kidney disease, and this slide will tell you how this graph of increase in mortality increases moment you develop a microalbuminuria or moment you develop chronic kidney disease defined at EGFR less than 60 mils per minute, 1.73 square meter surface area. It's not only cardiovascular mortality, but also look on your extreme right hand side, all cause death. So death due to any cause, exponentially grows higher once a patient develop a chronic diabetic kidney disease. Suffice to suggest that we need to protect these patients from ensuing diabetic kidney disease. Now, if someone has developed a diabetic kidney disease, you can see you reduce the lifespan by on an average 15 years. Somehow women are lucky, unlucky in the sense that they, if they develop diabetic kidney disease, their lifespan is even further reduced compared to men. Now, this suggests that we need to develop some tools to protect diabetic kidney disease. So I'm going to show you what has happened in past, 2 decades with regards to the tools which we tried to protect kidney disease and how did we fail to protect kidney disease with different, drugs tried so far in diabetic kidney disease. So this is a paper which is right now under submission, and I just reviewed what has happened in past 20 years with regards to protecting diabetic kidney disease. So I have brought you in front of you some of the trial which has been exclusively done to protect diabetic kidney disease. Let's start from those publications. It went back to 2005. When other than a RAS blocker drug was tried to protect diabetic kidney disease, and how we have summarily failed to protect ensuing diabetic kidney disease. So first in the list was a trial done with atorvastatin called a 4D study. It's a very famous study. People thought that, as you all know, that statin is a drug to protect you from a secondary, for the secondary prevention if you have got established cardiovascular disease. People thought that, whether using a statin can prevent diabetic kidney disease or even a cardiovascular risk reduction in patients with diabetic kidney disease. Surprised to know that in this 4D trial where atorvastatin 20 milligram was compared head-on to placebo, remember these are randomized controlled trial, double-blind randomized controlled trial. There was no benefit in the 3-point mesh. So the lesson number 1, when you are using a statin in a patient with diabetic kidney disease with a premise that you are going to protect these patients from the cardiac disease, you are absolutely wrong. And I don't know whether you have noticed it in the past or not. There was no benefit so far in the cardiovascular risk reduction in patients with CKD. Unfortunately, this trial landed up in a twice increase in the fatal stroke. Surprising. We always think that statin would protect from a stroke, but lesson number 1, it doesn't happen if you developed a chronic kidney disease. So 4D trial didn't do any benefit, rather shown harm. So there was increase in fatal stroke. That was the first, agent which was tried other than the, RAS blocker. The second drug was experimental. I'm sure Shailaja will remember these, where the questions during our MBBS days about PKC beta inhibitor. This was a famously, drug called roboxystorin. This drug was found to have some benefit for the diabetic retinopathy. So people thought that this drug could be useful to protect you from kidney disease. Unfortunately, from the 3 trials of diabetic retinopathy, like it's called PKC, diabetic retinopathy study, diabetic macular edema study, so pulled together from the 3 randomized controlled trial with roboxystorin, there was no benefit so far, for the kidney protection. The third molecule which was tried was the, elder brother of erythropoietin called darbepoetin alpha. It's called TREAT trial, and the people thought that patients with CKD who had anemia, if you increase the hematocrit and you improve the renal hypoxemia by increasing hemoglobin, you might protect the kidney. But unfortunately, in the trial called TREAT with darbepoetin alpha, there was no benefit in the renal or cardiovascular endpoint. In fact, this trial was landed with a twice increase in the stroke. So these are very interesting data, and basically we failed to protect kidney with any drug. The fourth drug, very popular, it's called ebocentan. It's an endothelin agonist, endothelin A receptor antagonist, which is non-selective, was also tried, at some point of time, somewhere in 2009, 2010. You can see this trial was stopped, called ASCENT trial with ebocentan, because there was increase in the heart failure in patients with diabetic kidney disease. So rather than doing anything good, there was increase in heart failure with very prospective molecule called ebocentan, endothelin receptor antagonist. Trial was tried with again experimental drug. This is TGF beta inhibitor called perfenidine. This drug, came into limelight during the COVID time. People do use for prevent lung fibrosis in post-COVID situation, although there is no data. However, this drug was tried in past for preventing diabetic kidney disease, and there wasn't any benefit. So you can see 5 different kind of drug, from statin to a PKC beta inhibitor to a derbopoietin alpha, endothelin receptor antagonist, TGF beta inhibitor. All these drugs failed. We didn't stop here. We keep on trying. You can see now another 4 set of trials in front of you. There was one randomized controlled trial called SINGH. It was tried with a molecule called sulodexide, which is a natural glycosaminoglycan polysaccharide. There was no benefit. Failed trial. The landmark trial, if you remember, was called Altitude. This trial was, why it is popular, because Altitude trial actually taught us, not to use a direct renin inhibitor. You remember, we were using L-Skyrin from Novartis very frequently, with a thought that if you directly block the renin-angiotensin system by using a directly renin inhibitor like L-Skyrin, you can perhaps protect kidney. Unfortunately, the Altitude trial was stopped prematurely, and this trial was, done with L-Skyrin versus placebo at the top of RAS blocker to protect diabetic kidney disease. And unfortunately, we couldn't protect, kidney disease, and in fact landed with more side effects of hyperkalemia and hypertension. And this trial was stopped prematurely. So, and since then, basically L-Skyrin was banned across the world. So again, another landmark trial with a very popular drug failed to show any benefit. The 8th trial was called Nephron D, and in fact this is one of the first trials where both ACE inhibitor and ARB was combined. As you can see, losartan was combined to lisinopril. So it was a combined ACE-ARB trial. Again, you can see there wasn't any benefit, and rather there was a harm, and because of that, this trial was again stopped prematurely. And this trial also taught us since then not to combine ACE inhibitor with ARB. These trials simply suggest, and finally you can see another molecule called bardoxolone methyl, which is an RF2 activators called Beacon trial. There wasn't any benefit, and in fact this trial was stopped because of increase in heart failure hospitalization. So you can see 9 molecules tried since 2005, or rather I would say from 2001 until 2019, 18 years, we tried 9 variety of molecule in diabetic kidney disease, and we failed miserably until, we have a newer class of drug. And I will show you that everything was not bad, although we failed with these drugs in past 18 years, but we had some hope that someday we will succeed. Now, when you look back into the positive trial, so I talked about all negative trials. Now, let's go back to 2001, that paper in New England Journal of Medicine, where you had 3 trials, simultaneously published in that issue of New England Journal of Medicine in 2001, where we had a publication of IRMA2 and IDNT with irbesartan, and one trial with losartan called renal. These are the 3 trials in 2001 that showed a positive outcome with regards to protecting diabetic kidney disease. The IRMA2 was a soft surrogate marker trials because it was just to look for the change in albumin level with irbesartan. So I will omit it. Let's look into the hard endpoint trial, which is IDNT, where the primary outcome was a composite of renal endpoint characterized by doubling of serum creatinine, development of ESRD, or death due to our renal or a cardiovascular cause. So that's a hard renal endpoint trial. And for the first time, we had one molecule to protect you from diabetic kidney disease, that was irbesartan, head-on compared to amlodipine and placebo 3-arm trial. Irbesartan shown a significant reduction in the renal composite endpoint. And this was replicated in another trial with losartan, that is called renal. And you can see again there was 16% reduction in the composite of renal endpoint. So this story is of 2001. And as I shown you, we failed miserably from 2001 onward till 2019, when we had a series of 3 trials published very closely. In fact, the SONAR trial and CREDENCE trial was presented at World Nephrology Congress, simultaneously in the same hall, one by one. And here in SONAR, elder brother of endothelin antagonist, I talked about ebocentan. Here it is atrasentan, which is a selective endothelin receptor antagonist, which was tried to, at the top of RAS blocker. And in fact, this trial shown a significant reduction in the renal endpoint. But this trial was, prematurely again stopped with the same reason which the ebocentan did in the same trial, that there was increase in hospitalization due to heart failure. So while in the SONAR trial, atrasentan showed significant reduction in the renal endpoint, but there was highly increase in the heart failure hospitalization that led basically this trial to a stop. On the same day, same time, another trial called CREDENCE, and I will come into detail for the first time. SGLT2 inhibitor came into the limelight, which is a dedicated renal outcome trial. And this trial was very similar to the SONAR in the sense that the canagliflozin reduces the composite of renal endpoint, but it was, in contrast to the SONAR trial, that it also reduced hospitalization due to the heart failure. This trial was also stopped prematurely, but for the good reason, which is in contrast to the SONAR trial that was stopped because of the bad reason. So in one hand, you have got a 2 molecule, where one molecule does protect from kidney disease in SWING, while other molecule, not only protect kidney but the heart as well. So the CREDENCE was the first dedicated diabetic kidney disease, outcome trial where you had a composite reduction in the renal endpoint as well as on the cardiovascular endpoint. I will come back to that. And followed by, we had data from the dapagliflozin, chronic kidney disease trial, DAPA-CKD. This trial was also stopped prematurely because of excess benefit. You remember somewhere in 2000, we had a hope and micro hope. This trial was stopped prematurely because of excess benefit with ramipril at that point of time. 20 years down the line, from 2000 micro hope to 2019-2020, you have got 2 trials with SGLT2 inhibitor, where trial was stopped prematurely because of the excess benefit. So something is there with this particular molecule called SGLT2 inhibitor. So in nutshell, when you go back to the history of the tools tried to protect diabetic kidney disease, and this figure summarizes what we have actually seen in the past 2 decades, that since 2001 publication of RAS blocker irbesartan, the IDNT trial and the losartan renal trial, we had to wait for 18 years to have first positive trial with canagliflozin CREDENCE, and then in 2020, the dapagliflozin trial is called DAPA-CKD, and very recently another molecule, which has been tried called a Fidelio DKD trial done with a pirfenidone, also found to have a significant reduction in composite of renal endpoint. In the meanwhile, whatever drug you tried, either they failed or they shown harm. That's the, the biggest message for past 2 decades. And to summarize about the tools, this slide tells you, different drugs tried in patients with both diabetic kidney disease as well as a non-diabetic kidney disease put together. And you would find then story from micro hope to IDNT to the CREDENCE. We had to wait for 18 years to have anything positive in front of us to protect diabetic kidney disease. So what did we do for last 18 years, in absence of any tool? We tried with a RAS blocker. That is the only tool we had, which we learned 18 years back in 2001. Now remember, if you are using a RAS blocker, there is a high residual risk still remains, and RAS blocker doesn't protect you entirely from the progression of diabetic kidney disease. And this slide in front of you suggests you how even using a RAS blocker left you in a lurch if you don't have another tool. Just it reminded me of a statin and residual risk. We keep on developing drug after a statin, for example, ezetimibe, and then we have got now variety of drugs which has been added into the basket of a statin to reduce residual risk. Similarly, in case of diabetic kidney disease, ARB is not enough, as you can appreciate. For example, in renal trial, by using a RAS blocker, you had protected 60% chance of kidney disease, but still more than 40% still left, and you needed a tool to protect diabetic kidney disease. The good news is that SGLT2 came into the limelight through these CB outcome trial. As you all know, the IMPAREG outcome trial was the first cardiovascular outcome trial presented with empagliflozin way back in 2015 at EASD at Stockholm. We all were present when the IMPA-REG outcome was presented in front of us. And since then, now we had number of trials done with SGLT2 inhibitor. Now, although these trials were primarily meant to, show the cardiovascular safety, but the renal endpoint were the exploratory endpoint in these CB outcome trial. And if you closely look in this trial, I'm sorry, I would have added even Bertie CB and a SCORE, put into together here. However, in both Bertie CB and the SCORE, the renal outcome trial didn't become positive. But if you go there in IMPAREG, CANVAS, and DECLARE TIMI, these exploratory endpoint, renal endpoint composite, were found to be highly statistically significant. So this suggested us, in fact, that hinted us that SGLT2 inhibitor not only protects you from heart disease, but also protects you from diabetic kidney disease. But with a caveat that the renal endpoint were not a primary objective. These were the exploratory endpoint. So any benefit in these CB outcome trial will only be a hypothesis, not the final proof. And therefore, you need to conduct a dedicated renal outcome trial in patients with diabetic kidney disease with a renal endpoint as a primary outcome. However, from these CB outcome trial, we learned certain lessons. And what are those lessons? If you see this meta-analysis in Lancet with these 3 CB outcome trials, for the first time we learned that the benefit in renal composite endpoint, it not only happens in patients with established cardiovascular disease, but happens to every diabetic patient. So to benefit with SGLT2 inhibitor happens to every diabetic patient, irrespective of presence or absence of cardiovascular disease. So the heart failure benefit, hospitalization, and the renal benefit doesn't require to have established cardiovascular disease. SGLT2 inhibitor protect kidney and protect heart failure hospitalization in every Tom, Dick, and Harry if you have got a diabetes. That's a simple message. But to reduce the major adverse cardiovascular endpoint with the SGLT2, you need to have established cardiovascular disease. So that's the simple lesson which has been taught by these CB outcome trial. As I said, the renal benefit cannot be considered final because you need to conduct a dedicated renal outcome. So let's look into this space with SGLT2. Now there are a number of trials which is already now published. In fact, almost all the trial is published barring IMPA renal outcome trial, which I have put as a purple color in front of you, which is expected in 2021 mid, somewhere at ADA in 2021 it will be presented. But then other than the IMPA renal trial, other outcome trials in patients with chronic diabetic kidney disease already are. As I said, the CANA was the first trial, CREDENCE, and I will show you those data, shortly. Dapagliflozin also conducted DAPA-CKD. There were a smaller randomized control trial called DELIGHT, but these, endpoints were very soft endpoint, like albuminuria reduction was the, endpoint in DERIVE and DELIVE. So basically, when you are looking into a diabetic kidney trial, we will talk about CREDENCE, DAPA-CKD, and IMPA-RENAL. IMPA-RENAL is not all. So let's see what happened in the dedicated renal outcome trial called CREDENCE and DAPA-CKD. How is the difference between two trials with regards to inclusion, with regards to the outcome, and what is our conclusion with SGLT2 in diabetic chronic kidney disease? You have seen this slide umpteenth number of times. Just to recapitulate, that the CREDENCE trial was the first dedicated, trial conducted exclusively in patients with diabetic chronic kidney disease who has had, albumin in urine, which was extending from 300 to 5,000. Everyone was supposed to have a EGFR ranging from 30 to 90, and it was conducted in patients who were more than 30 years of age. And a 100 milligram head-on compared with placebo, double-blind randomized controlled trial, 1:1. And here is the, objective of this study. What we need to understand in the CREDENCE trial, these trials were statistically powered in a certain fashion. Still, even if you are a physician, you need to learn a little bit of statistics, because when pharma company will come in front of you, you need to understand a little bit of statistics to actually understand what happened in these, renal outcome trial. So in the CREDENCE trial, the primary objective was the composite of renal endpoint, as you can see in front of you. However, this trial was statistically made in a fashion that if you, win the race on the primary objective, then you are supposed to look for the second bullet, which was the composite of CV death or heart failure hospitalization in the CREDENCE trial. So these trials were primarily made in a fashion that if you achieve the superiority in the primary objective, then you need to look for the secondary objective according as per, it was pre-specified in a pre-hierarchical manner. So the CREDENCE was pushed in a manner that primary objective was the renal endpoint. The second objective was to look for composite of CV death heart failure. The third objective was to look for the composite of 3PMS. The fourth objective was to look for hospitalization due to heart failure, and so on and so forth, as you achieve the superiority in each point. So remember, the law of game, for this particular trial was that if anywhere you did not achieve superiority, henceforth no statistical calculation would be done. So what happened in the CREDENCE trial? As you have seen a number of times, there was a significant reduction in the composite of renal endpoint. As you can see, there was a 30% relative risk reduction in the progression of diabetic chronic kidney disease in the form of renal composite, which was a huge and perhaps the first evidence available till date in patients with diabetic kidney disease that an anti-diabetic drug can reduce the renal endpoint. Now, when you look back into all those, points which I talked about in the statistical hierarchical fashion, you can see the first bullet, that is the primary objective, was met. So you go for the second objective, which is a CV death or heart failure, and now you can see there was 31% reduction in the CV death heart failure composite. If you see the 3PMS, there was 20% reduction. So basically, canagliflozin for the third time, remember in the CANVAS program was a mixture of two trials, CANVAS and CANVAS-R. Now here I have got a third trial in the CREDENCE. So basically, canagliflozin has undergone a 3 cardiovascular renal endpoint trial. And in all the endpoint trial, there is a significant reduction in the cardiovascular endpoint. Although the CREDENCE was a primary renal endpoint trial, but the cardiovascular endpoint was the secondary endpoint in the trial. Okay? Now you can see even, reduction in the cardiovascular endpoint trial was larger than the actual CANVAS program, which was a composite of CANVAS and CANVAS-R. So this suggests that the benefit with the canagliflozin in the CANVAS program didn't came by a fluke. And you can see repeatedly that benefit in the heart failure or the composite of CV death or heart failure is replicable. Number of times you do the trial, you are going to achieve the benefit. And what is interesting, that in the CREDENCE trial, both 3P MES and the heart failure benefit was larger than even the CANVAS program. And this is expected considering these are the patients who are renally sick. So if a drug has got a potential to protect you from heart failure, it will protect larger if your patient has got a kidney disease, because these patients are more prone to develop heart failure. And as I said, this was replicated in the CREDENCE trial. So that was about the CREDENCE trial. The similar kind of trial was conducted with dapagliflozin, and difference between DAPA-CKD and CREDENCE trial was in terms of inclusion criteria. In the DAPA-CKD trial, the EGFR was brought down from 30 to 25. Now let's see the difference between CREDENCE and DAPA-CKD. In the CREDENCE, the cutoff was 30 to 90. In the DAPA-CKD, it is from 25. If you see the albumin creatine ratio cutoff, it was further brought down from 300 to 200 in the DAPA-CKD. In CREDENCE, the lower limit was 300. The difference in DAPA-CKD that this is not a trial which is conducted exclusively in patients with diabetes, but it do have patients of kidney disease other than diabetes. So this is a trial which was done in patients with CKD even without DKD. So this trial consisted of both CKD without DKD as well as DKD. Now, if you see the statistical planning of this trial, this was, ditto of the CREDENCE trial. So the primary objective was the renal composite, and it was a dedicated renal outcome trial. And again, it was put in a statistical hierarchical fashion that if you do a renal objective trial and if you achieve superiority, then you look for the cardiovascular outcome trial or the all-cause death, etc., if you achieve the superiority endpoint. So what happened in the DAPA-CKD? Here is the result. You can see there was a 39% reduction in the composite. Remember in CREDENCE it was 30%. Now it is 39% in the DAPA-CKD. So you basically see that you have got a two trial here with a SGLT2, which replicated the renal benefit finding in patients with not only the diabetic kidney disease, but also non-diabetic kidney disease. Now, if you see the other endpoint in the DAPA-CKD, again, it's almost a ditto copy of what we see in the CREDENCE trial. There was 39% reduction in the composite of CB death and heart failure with dapagliflozin. Remember, in the CREDENCE, in the declared TIMI trial with dapagliflozin, the composite of CB death and heart failure was only reduced by 12%. Now here in the DAPA-CKD, there is a 39% reduction, 29% reduction in the composite of CB death and heart failure. It suggests that if your patient has got a diabetic kidney disease, even benefit in the cardiovascular endpoint would be larger compared to someone who do not have a kidney disease. What was additional in the DAPA-CKD that there was reduction in the all-cause death. Now, if you compare these two trials put together, which we always tend to do, we need to always go for a comparison between two molecules, although you should not do because of a certain difference between the baseline characteristics between CREDENCE and DAPA-CKD. However, if you look into the result of CREDENCE and DAPA-CKD, what you find, there is more similarity than the dissimilarity. The only difference which happened in the DAPA-CKD that there was a significant reduction in all-cause death by 31%, which wasn't statistically significant in the CREDENCE trial. Although there was 17% reduction in the all-cause death with the canagliflozin, however, it did not achieve a statistical significance, but it met a statistical significance in the DAPA-CKD. That's the only difference between CREDENCE and DAPA-CKD with regards to the outcome. But where is the difference between these two trials? As you see the inclusion criteria. Now, if you look into the DAPA-CKD, now you can make out that there are certain differences between two trials. What are those differences? Let's look here. In the DAPA-CKD, the patients were more renally sick, whereas in the CREDENCE trial, patients were more cardiologically sick. If you see the DAPA-CKD, 37% patient had established heart disease and 11% had heart failure at the baseline. In contrast, if you compare with the CREDENCE trial, there 50% patient had heart disease, established cardiovascular disease, and 15% had baseline heart failure. So if you compare both the trial, very simple difference. In the DAPA-CKD, patients were more renally sick because the eGFR was brought down from 30 to 25. The albumin creatinine ratio was brought down from 300 to 200. Whereas in the CREDENCE trial, you have got more patients with established cardiovascular disease and the heart failure, so they are more cardiologically sick. Now, when you are comparing the result of these two trials, also you need to understand the difference in the patient characteristics between the CREDENCE and the DAPA-CKD trial. Now, so simple advice is not to compare between two drugs, but to look it as a class effect. Now, you have got two trials like CREDENCE and DAPA-CKD which shown benefit. No wonder if you see the different guideline in the world. So this is the guidelines from ERA and EDTA. So this is Kidney Society, Nephrologist guidelines, and Dialysis Society guideline. Now, for the first time, they started realizing that if you have got a patient with diabetic kidney disease, you need to use a SGLT2 inhibitor to protect diabetic kidney disease. Now, if you see the current KDQI guideline and this KDIGO guideline published a month back, they also recognized the importance of SGLT2 inhibitor, and they put SGLT2 now in front to protect you from diabetic kidney disease. Remember, there is one caveat with this KDIGO guideline. This guideline was published prior to the DAPA-CKD result was odd. So this guideline actually took consideration only of the CREDENCE trial, and still they recommended that if you have got a patient with diabetes with a chronic kidney disease, if the eGFR is more than 30, you need to introduce SGLT2 inhibitor at any cost. So let's see the analogy between ADA-ESD guideline, where basically that compelled you to use a SGLT2 inhibitor if you have got a established heart disease or a heart failure or CKD. Now here KDIGO guideline basically compels you that if you have got a patient with diabetes with kidney disease, if eGFR is more than 30, you introduce SGLT2 by any means. By any means suggests that even if the HbA1c is good, you reduce the dose of other drug except metformin and introduce the SGLT2. Of course, if the HbA1c is not under target, then add the SGLT2 inhibitor. Simply, this KDIGO suggests you that SGLT2 inhibitor needs to be used to protect diabetic kidney disease. Now, I'm sure even the next KDIGO guideline would take it further, because the DAPA-CKD and the IMPA-renal data, which is going to come soon, would be added into this, and this guideline will give a grade 1A evidence for SGLT2 inhibitor to protect diabetic kidney. Ladies and gentlemen, I will finish my presentation by simply suggesting, now if you have given a choice to choose between SGLT2 inhibitor with regards to protecting diabetic kidney disease and heart disease, these are the level update till November 2020. Remember, IMPA has got a level as of now only for the CV death reduction in patients with diabetes with established cardiovascular disease. We expect that once this the data of the IMPERA reduce would be put in front of US FDA, they will get an additional level exactly like the dapagliflozin which they got from the DAPA heart failure. But as of now, IMPA has only level of CV death reduction in patients with diabetes with established cardiovascular disease. The next in the line was the CANA. The CANA got 3P MES reduction, in patients with diabetes with established cardiovascular disease. Although there is little difference between FDA and EMA level, FDA gave them a level only in a patient with established cardiovascular disease, whereas the European Union gave CANA also in a patient with primary prevention. So the 3P MES level is only right now with the canagliflozin. The CANA also got the additional level from the CREDENCE trial that this should be used to protect you from the renal progressive disease and to reduce heart failure hospitalization in patients with diabetic kidney disease. On the other hand, the DAPA got the additional level for heart failure hospitalization based on the declared TME trial in patients with diabetes. And from the DAPA heart failure, they additionally got the additional level to be used in patients with heart failure with reduced ejection fraction, even in absence of type 2 diabetes. So DAPA is the first anti-diabetic drug which has been recommended to be used in a non-diabetic patients with a reduced ejection fraction heart failure. So when it comes to a diabetic kidney disease, at this point of time, only canagliflozin has been given a level up. But I'm sure, 3 months down the line, the DAPA is also going to get it exactly similar in fashion like the canagliflozin in patients with diabetes. But I am not 100% sure that DAPA would be again permissible in patients with non-diabetic kidney disease. Although in the DAPA-CKD, you have got both kind of patients. Let's wait and watch whether FDA give additional level of DAPA even in patients without diabetes but with a chronic kidney. Thank you very much for your patience listening.
Thank you so much, Dr. Avdesh. As usual, thanks a lot. Superb kind of a review, as well as your own thoughts, which is going to help my viewers to take decision in day-to-day clinical practice. I think there are a lot of questions from our viewers. So let me just have one question multiple times asked, which depends on your last line. What is the indication of SGLT2 inhibitors used if the GFR is 30?
Yes.
Or 30. So we'll use
No.
in a person with diabetes.
Right. So, if you look into the earlier version, the good thing is, ADA EST has got a dynamic algorithm now. So they keep on changing that. It's not like that every year only ADA EST guideline will come with a position statement. Now, since 2019, ADA EST has got a dynamic algorithm. So once a trial data is out, they change their guideline. As I suggested, the EGFR cutoff was brought down from 45 to 30 when the result of CREDENCE trial was published way back in 2019. So as of now, you have got a permission to use a SGLT2 inhibitor in patients with diabetic kidney disease if the EGFR is more than 35.
Yes. So this question from Dr. S.P. Kalra. So on the similar line, there is a question that I think Dr. Rajendra Paswala has also asked the similar question. I think both of them they got their answer. Now, that you have already mentioned in your talk, there is a question that in a non-diabetic CKD, is SGLT2 inhibitors at present indicated by label?
No, right now, no. But I don't know if FDA is looking into the DAPA-CKD data. Perhaps knowing the nature of FDA, they will wait for the IMPA renal trial as well before giving an additional level update in patients with non-diabetic kidney disease. But for the moment, SGLT2 inhibitor is only given in a non-diabetic situation in patients with heart failure with reduced ejection fraction, not with non-diabetic kidney disease.
Okay, there is a question from Dr. Om Prakash. I think you both of you can answer this. This is about the use of SGLT2 inhibitor in the presence of infections in urinary tract as well as prostatic infections, recurrent cystitis. So there is because initially there was a lot of fear and question mark of using these drugs whenever there is an infection. So what is your take, Dr. Avdesh first and then Dr. Lobo?
Well, so, Shailaja, this is a very common question asked by physicians, and sometimes I really feel amusing. I mean, we are not in a hurry to use this drug, boss. If someone has got active infection or recurrent, UTI or genital tract infection or cystitis or pyelonephritis, why are you in a hurry? Protecting diabetic kidney disease is not a matter of prescribing a drug for 7 days. Let's cure the problem. As you know that this drug has only drawback by virtue of their mechanism of action, that this drug has a potential to increase genital tract infection or sometimes when a recurrent UTI, because this drug throws glucose through the urine. Why one should be in a hurry? Let's treat the condition, and you have got a whole life to prescribe a SGLT2 inhibitor to protect diabetic kidney disease. So my simple answer would be that you treat the active infection. At that point of time, don't be over enthusiastic to use a SGLT2 inhibitor. Correct the problem, and then you introduce the SGLT2 inhibitor. So I don't think this is, big deal, about all those precautions.
Yes, Avdesh, you are right. My first case of euglycemic diabetic ketosis, when I used an SGLT2 inhibitor in a patient with recurrent UTI, typical women around 55, 60, and we have lot of diabetes which have recurrent kidney infection. So my first case of euglycemic diabetic ketosis, when I use SGLT2 inhibitor in such a case. So one should be careful. You want
One
to
should-
add something?
No, I think he has answered it completely. Treat the infection, make sure there is no infection, and then add it on. Keep a close look on the urine routine, etc., from time to time, so that we can be sure of picking up a pyuria early. If there is a abnormal lower tract,
Doctor's
say
name also.
a diabetic cystopathy or an obstructive uropathy, then ensure that those are taken care of so that other risk factors are out of the way before starting the SGLT2.
Okay, so there's one interesting question. I think I will ask you, Dr. Valentine. Dr. Vinay Gupta has asked, what is the management of albuminuria? So even I think I was going to ask you, should we chase proteinuria when we are treating, or should we just use drugs which protect kidney in the presence of albuminuria?
Yeah.
Should we chase it by managing increasing drugs? What's your
Okay,
take on that?
right. So albuminuria is a surrogate, one. Second, albuminuria is a continuum. So there was a time when, in fact, you showed that slide earlier, the CKD, KDIGO classification of CKD, where we used to say microalbuminuria between 30 to 300, normoalbuminuria less than 30, and overt albuminuria more than 300. Today, we would accept that even a value moving from 10 to 25 in the normal albuminuria range is still an increase in albuminuria, and we need to watch it more carefully. We also need to ensure that this is not a temporary phenomenon. So if we are dealing with microalbuminuria, or as they call it, no, the moderately elevated albuminuria now, then we would do 3 values at intervals of 6 weeks and make sure that yes, the patient really is in the elevated albuminuria range. If it's more than 300, then yes, we would start treatment. How aggressive should we be before to lower it? Well, what has been said is, if you can lower from a value which is more than 300 to less than 200, the chances are that benefit will be obtained. There is also a study, I think it was with candesartan, which looked at what was the benefit of albuminuria reduction when we went above the hypertensive dose of candesartan. So 16 milligrams is the maximum antihypertensive dose, and patients were randomized to 16, 64, and 128 milligrams. So 128 would have been 8 times the maximum antihypertensive dose, and there was a benefit seen both for albuminuria and when the patients were followed up long term in a hard endpoint of doubling of serum creatinine. So higher the dose used and lower the albuminuria, that study did show a benefit.
Even irbesartan,
Irbesartan
IDNT
subsequently,
also used.
IDNT also used.
Okay.
2 different doses.
Okay, so we need to look at the both GFR as well as the albumin, and we both need to monitor when we are treating.
Which is why that slide of yours showed
Yeah,
it very
both
nicely,
X
that
and
both
Y.
need to be looked
Yes.
at.
So I think we always talk about how the benefit of the cardiovascular benefit and the kidney benefit are interlinked. So Dr. Rajiv Arde is asking that, can we say now that the improvement in the heart failure leads to better renal perfusion and hence the renal protection? But that's only for the, I think, heart failure.
Heart failure.
Like even though in the absence of heart failure,
There is still a benefit.
renal protection. Okay, so there is one question from Dr. Murlidhar. What is the role of diuretic drugs in diabetes? So I don't know. I will not take this as a, because we know they are very good for heart failures, of course. Though the need of diuretic goes down once we add SGLT2 inhibitors, and one should be careful in reduced ejection fraction.
Yes.
When the patients are on diuretic, when we add ERNI plus SGLT2 inhibitors, slowly we need to reduce diuretics to avoid that hypotension. Its drug as an antihypertensive is great.
Great.
It's great. I think these are the drugs which reduce mortality.
Yes.
Like diuretics, beta blockers. I think very few drugs which have hard outcome as a reduction in mortality. One of them is diuretic.
So
I want to say something.
As you just said, that we need to recognize that in CKD, salt and water retention is the contributor. 95% of patients, the major contributor to hypertension is salt and water retention. So in this situation, diuretics are invaluable, and we all know that control of blood pressure is the most important intervention that we can make. So if a diuretic will help us to control blood pressure, will help us to control edema, which may not be having a long-term a harmful effect, but which can be distressing to a patient or limiting to a patient, then diuretics definitely have a role. Does the class of diuretics, or do diuretics as a class have renal protection in diabetic kidney disease? Is not by themselves, but to take care of salt and water, definitely.
Yes, so in lot of patients, I will say the benefits as an antihypertensive,
Yes.
as an adjunct to the, because we always
Yes.
need 3 drugs
We
to
always need
control
treatment.
hypertension,
Absolutely.
and it is useful. That negative connotation with diuretics because of its metabolic
Yeah.
effects on glucose, I think it is irrelevant when we use in a smaller dose of hydrochlorothiazide
Agreed.
or chlorothalidone.
Yeah.
So thiazide or thiazide like diuretics,
Yeah.
I don't think the metabolic effect in the dose which we use have a deleterious effect
They
on the
don't.
glucose metabolism.
No. And
So that should be gone, and we should use these drugs, and because of their benefits in blood pressure as well as mortality benefits.
yeah.
Yes. So Dr. Avdesh, this is again a question that do you have any specific choice for CANA or DAPA? You showed a beautiful last slide. I am really happy with that, which actually made clear that on 10th December 2020, what are the correct indications of different SGLT2 inhibitors. But I think someone wants to know that if the GFR is 30, what will be your choice at present in a diabetic kidney disease?
Yeah. So actually, I have added there that you choose your SGLT2 of your choice. By this time, you know which one to choose. Well, as I said, I don't see any big difference between CANA and DAPA with regards to the renal protection. But you know, one point is very simple. On paper, although if you ask me, both has got a very similar outcome. Uh, Cardiovascular death reduction was seen in the DAPA-CKD, which was not statistically significant in CREDENCE, but both trial is completely different in direction. When you are talking about a diabetic kidney disease, now the convincing data is with the CREDENCE compared to the DAPA. There is no fact denying that at this point of time, the only CANA has got a level update for diabetic kidney disease protection. So unless FDA give dapagliflozin similar kind of level update on paper, although I believe there is no difference between DAPA and CANA with regards to the kidney protection, but from the proof or the scientific evidence level update, the CANA is little bit ahead of the DAPA just because of this level update, nothing else. Both the drug works in the similar direction.
Thank you so much, Dr. Avdesh. And I think you have also said this in your lecture that initially these drugs came as a reduction in proteinuria for and protecting the kidneys. For many years, the research was going on. Then it was, I think, overtook by cardiovascular trials, and then again came back to kidneys. But I think the CVOTs helped us to show that reduction in proteinuria and some benefit of the kidney, so that I think making such a trial for kidney patients is difficult. It's not that easy to use such drugs. So I think CVOTs gave the confidence, and then of course the CREDENCE came. And
also, as I think he showed in one of his early slides, ultimately chronic kidney disease patients die of cardiovascular deaths.
Yes.
So that is what is the bottom line.
So whatever happened was correct.
Correct.
So we are taking cardiovascular risk first, and now we are also protecting kidneys. So I think we are at the end of the session. Actually, we are 15-20 minutes past 8 o'clock. But my viewers were asking the questions. Thank you so much. So I thank from all my family of Diabetes Dilemma everyone. Personal thanks to Dr. Avdesh. Thanks to Dr. Valentine Lobo and everyone which is involved with Diabetes Dilemma. This particular session, I thank USV for sponsoring this session and all my sponsors of Diabetes Dilemma series. Thank you so much. Thank you. Yes.
Bye. Take care.